be talking about bipolar disorder. Today what I'm going to do is provide a brief introduction to bipolar disorder, talking about exactly what it is, symptoms, prevalence, etc. We'll then talk about the classic and really gold standard treatment for treating bipolar disorder, which is lithium. In our next lecture, we'll talk about newer drugs used to treat bipolar disorder and their ups and downs, and some alternatives to those drugs. But for now, we'll start off talking about exactly what is bipolar disorder. There are several different classifications of bipolar disorder. Bipolar disorder is an affective disorder similar to major depressive disorder. In fact, we talked a little bit about it when we talked about antidepressants. Bipolar 1 includes at least one episode of mania. We're going to talk about the symptoms of mania here in just a moment. Bipolar 2 includes major depressive and hypomanic episodes, so more depression and lighter, less severe mania. Bipolar 1 tends to be much more problematic mania, which can sometimes include psychotic symptoms, some serious issues including reckless spending, lots of impulse control, etc. Cyclosmia is sort of the bipolar version of dysthymia that we talked about previously. It's a less severe form of bipolar disorder, but certainly can be disruptive. And then finally, we have what's called bipolar NOS, or not otherwise specified. Oftentimes, this is the catch-all. We can't figure out where to throw somebody, so we call it not otherwise specified. So this tends to be only people with hypomania. So to give you a little bit of an overview of what this looks like, people with bipolar 1 have manic and mixed episodes, for sure, possibly hypomanic, possibly depressive episodes. Bipolar 2 will always include hypomanic episodes and depressive episodes, and cyclosmia, it will include hypomanic episodes but not major depressive disorder. So these are the sort of basic criteria for bipolar disorder. Again, we're switching to DSM-5. We'll talk more about that when it comes out. So, some symptoms of mania. Obviously, we've already talked about depression, but mania can include people being overly cheerful and exuberant, very articulate and jocular, outgoing, lots of fun and outgoing. To give you a pretty clear example of somebody with bipolar disorder is Robin Williams. Overconfident, self-assured, boastful, grandiose, extroverted, people-seeking, high energy level, full of plans, versatile with broad interests, over-involved, uninhibited, and stimulus-seeking. In fact, there's a lot of substance abuse that goes along with bipolar disorder because of all of these other things that go with it, particularly that impulse control. Other symptoms include irritability, excessive high-risk activities, including excessive sexual activities, substance use, theft, all sorts of crazy stuff like that. There is often inflated self-esteem, very grandiose kinds of behaviors, flight of ideas, distractibility, and a decreased need for sleep. When we talk about some substances like cocaine, amphetamines, oftentimes these are similar to the symptoms of cocaine or amphetamine use. So there's going to be some similarities there. So obviously there's probably some tie-in with dopamine and the other neurotransmitters involved in those drugs. In order to distinguish hypomania from just people being happy, obviously it's good for people to be cheerful, but hypomania can be fairly clearly different. So cheerfulness will switch easily to irritability when the person is crossed, whereas somebody who's happy, their mood is even and not so easily perturbed. The hypomanic person has this drivenness and energy, whereas the person who's just happy can settle down and sort of be normal. Hypomanic people will sleep less than normal, whereas just happy people will get a full night's sleep. Happy people will have good judgment, whereas hypomanic people will have grandiose ideas leading to poor judgment. With happiness, there's no predictable relationship to depression, whereas with hypomania, there is oftentimes depression or psychomotor retarded hypersomnic type of depression. So there's oftentimes preceded by or followed by these kind of depressive episodes. And again, in a hypomanic person, this is cyclical, sometimes timed to a specific time of the year, whereas with happiness, it's generally not seasonal. To give an idea of who has bipolar disorder, that is the epidemiology of bipolar disorder. It's about 1% overall populations. For bipolar disorder 1, there tend to be more, males and females tend to be affected equally. For bipolar disorder 2, females tend to be affected more than males. The first symptoms of bipolar disorder tend to emerge at age 15 to 19, but there tends to be a long delay before the correct diagnosis and treatment of bipolar disorder. In fact, most people are diagnosed in their 30s. Oftentimes, what's confused with simple adolescent behavior is actually bipolar disorder behavior. And obviously, by the time someone's in their 30s, we expect them to be responsible adults, and so the expectations about their behavior change, but they're not able to change their behavior. There is a significant amount of mortality associated with bipolar disorder. 25 to 50% of those affected by this disease will attempt suicide. Around 19% of those people will succeed. There is a risk, the overall risk of developing bipolar disorder is about 0.5 to 1%. The incidence of new cases per year is about 0.01% for men and 0.01 to 0.03% for women. So it's not a common disease, but it's certainly a devastating disease, and that's what's important. Unipolar mania occurs in about 1% of the population of bipolar patients, so people who just have mania with no depression. So it's a really rare disorder. And again, onset is usually by the third decade, that is in our 20s and 30s, but can occur later. Okay, so our 20s is our third decade, and so this is when the disease tends to be diagnosed in the 20s and 30s, whereas it probably has its onset in our teens. So here is a survey of symptom onset. Again, tends to be clustered around 15 and 19, with another big clump of people at age 30 or above. As you can see, there are patients who are diagnosed at earlier ages. I question those, but it's not my expertise. I'm just not sure how you can discriminate a bipolar toddler from a regular toddler. To look at some clinical issues, most patients will come in seeking treatment for depression rather than the bipolar or the mania portion of their disorder. There tends to be a significant delay between onset of symptoms and the correct diagnosis and treatment, as I mentioned earlier. Bipolar spectrum disorders generally have a stable course over time, so if you are watching a patient for a long period of time, you can see a sort of regular, stable course or time course, and it can be predictable. Again, suicide rates are high in bipolar disorder. And unlike depression, in the initial phases of bipolar disorders, there are precipitants. That is, there are things that will oftentimes precipitate an episode, whereas in major depressive disorder, there really oftentimes there's nothing to precipitate. It's just simply a neurodegenerative disease. Now, it's important to understand there is a relationship between bipolar disorder and major depressive disorder, and it comes back to that intracellular signaling and neural dysfunction hypothesis we talked about previously. It all comes back to that. So to wrap up some of our clinical issues, only 20% of patients who are screened positive for bipolar disorder actually receive the diagnosis, but 31% receive diagnosis of unipolar depression, and about half of them receive no diagnosis. So we probably have some issues with diagnostic accuracy to think about. Of those diagnosed correctly, most were not treated adequately. That is, they tend to receive antidepressants without a mood stabilizer. Now, one of the problems with giving a bipolar disorder patient an antidepressant is you will get what's called the manic flip. That is, they will flip into a manic episode based on the addition of an antidepressant. So that's certainly something to watch out for. Again, nice summary here of the clinical features that distinguish between major depressive disorder and bipolar depression, and clinical features that may suggest bipolarity in patients presenting with depressive symptoms. Again, unipolar depression usually emerges after the age of 25 years, whereas bipolar depression before 25. Unipolar depression preceded by an extended period of gradually worsening symptoms, whereas bipolar depression episodes may be abrupt in onset, that is hours or days. These are often periodic or seasonal, You will get treatment-emergent mania hypomania during antidepressant therapy. It's highly heritable. So bipolar disorder often runs in families. In fact, there's a theory of what's called repeat nucleotide expansion. That is, each successive generation of individuals with bipolar are more likely to have bipolar disorder, and it's likely to be more severe. And again, there are clinical features that suggest bipolarity in patients presenting with depressive symptoms. Individuals with a history of antidepressant failures may be at risk for bipolarity. Antidepressant-induced activation, so if you get those mania symptoms from antidepressant activity, likely could be somebody who's bipolar. Some behavioral disruptions, and any history of manic or hypomanic symptoms are all more likely to indicate bipolar disorder than manic depressive disorder. There are some particulars of mortality in bipolar disorder that I think are important to quickly cover. Poor occupational status before an index episode, that is somebody who's out of work, unable to maintain an occupation, is at risk for suicide. Any history of previous episodes, history of alcoholism, psychotic features. Oftentimes mania can be associated with psychosis. Symptoms of depression during an index manic episode, which we call mixed mania, so they're both depressed and manic at the same time. Men are much more likely to attempt suicide or be successful at suicide, particularly those who are bipolar. And then if you get inter-episode affective symptoms, that is disruptions in affect in between episodes, these people are more at risk for mortality. So it's important to get a good clinical picture and particularly a good history of a patient when treating somebody with bipolar disorder. Okay, that's a very quick and brief introduction to bipolar disorder. If you're interested in reading further, I certainly suggest reading the textbook in detail. There are lots of resources online. I'll try to post a few to Blackboard. And certainly taking abnormal psychology is a good resource for learning more about these disorders. So next I want to turn to starting to understand how we treat bipolar disorder. There are several classes of drugs used to treat this particular disease. The first we're going to talk about today is lithium. This is a classic drug that's used to treat bipolar disorder. It's the most effective, but it has some serious side effects and some serious toxicity. So it's not always a choice that will work. We can also treat bipolar disorder with anticonvulsant mood stabilizers. These drugs were primarily designed to be anticonvulsants, but also work as mood stabilizers. We'll talk about various drugs and their efficacy for that. Some atypical antipsychotics, or almost all atypical antipsychotics, can be used to treat mania. And then finally, there's some evidence that omega-3 fatty acids might be efficacious in treating some symptoms of bipolar disorder. So these are the classes of drugs used to treat bipolar disorder. I want to focus for just a minute on why treatment is so critical. This is a very disabling disease and really is a significant effect of has a significant effect of disability on those who are afflicted. So treatment is critical. There is a basic loss of up to 9 years of life on average based on bipolar disorder mortality. Patients can lose up to 14 years of effective activity because they're out so long with their episodes. Can lose 12 years of normal health. 20 to 25% of untreated bipolars will attempt suicide, and maybe as high as 10 to 15% completion rate, which is really unfortunate. 60% of these patients will have a comorbid substance abuse disorder that I talked about previously, and only about a third of patients are in treatment. So it's a really undertreated disease, an poorly understood disease, and certainly something we need to think carefully about. So treatment is critical, and we're going to focus in this lecture on lithium. So we're going to talk first about what lithium is, talk a little bit about its history, of course, talk about its pharmacokinetics and pharmacodynamics, spend some time on the side effects and toxicity associated with lithium, and then finally wrap up some issues in lithium treatment, including the problems with lithium as a teratogen. So let's start off by talking about what lithium is. Historically, this is the drug of first choice for treating bipolar disorder. It's the lightest of alkali metals. It's much like sodium, Potassium, so it's an alkaline metal, so if you remember in your chemistry. Importantly, it has no psychological effects in healthy people, so there's no chance for abuse because it's just a salt. But it is effective in treating 60 to 80% of acute manic and hypomanic episodes, so it's pretty efficient at treating mania and hypomania. Unfortunately, there are some serious issues with toxicity and compliance, and so alternative treatments are necessary. We'll talk about what some of those available alternatives are. So that's a brief introduction to lithium. We'll talk about the history behind lithium next, and then we'll get into talking about its pharmacokinetic and pharmacodynamic properties. So here's where lithium came from. It was first introduced as a salt as lithium chloride, much like sodium chloride, the salt we use every day. So it was introduced as a salt substitute in the late 1940s. Unfortunately, there was some severe toxicity associated with its use, and we'll talk about that toxicity in a moment. There is a very narrow therapeutic range with this drug, and so anything above that does lead to some serious toxic side effects. So we get to the 1970s, and there is research that determines that it's effective in treating mania. There was resistance to using it as a treatment because of its known history as being toxic, and particularly cardiotoxic. So there have been, since the 70s, many controlled studies demonstrating its efficacy in treating mania and depressive episodes in bipolar disorder. It is a really effective drug. Unfortunately, it's just very difficult to keep people on, and to do so safely. So finally, treatment with lithium requires close monitoring because of its potential toxicity, but it is the gold standard for treating bipolar disorder. In fact, it has the most appears to be the most effective of all the treatments available. So it's effective, but it is problematic, which is unfortunate. We'll talk more about some of those side effects here in a bit. So let's take a look at the pharmacokinetics. It's rapidly absorbed. Peak blood levels are reached within 3 hours of oral administration. It's completely absorbed by 8 hours. Its therapeutic efficacy is fortunately directly related to its plasma levels, although the levels available in the brain are much lower. So not a lot of it crosses the blood-brain barrier, but enough to get that therapeutic efficacy. So monitoring plasma levels of lithium is a good way to determine its therapeutic efficacy. So they are directly related, which is fortunate. One of the things with lithium is it gets absorbed into lots of peripheral cells, and so it's available long after it's been administered. And so if you reach toxic levels, it's difficult to get those levels back down because it's so widely distributed. Lithium is not actually metabolized, but rather it's excreted unchanged by the kidneys, although some of it can be excreted through sweat, just like any other salt. Steady state of this particular drug is reached after about 2 weeks. Again, some of it related to its metabolic rate and where it gets distributed into these peripheral tissues. There is a very narrow therapeutic range, which we can verify by checking the blood levels of our patients, because we can actually test how much lithium is available in their blood. And essentially, anything below 0.6 per liter is ineffective, and anything above 2.0 per liter is toxic. So it's a very narrow therapeutic range. And oftentimes what happens is we titrate patients into that appropriate effective range, which means they have to have their blood drawn a lot, and then even after we get into that narrow range, they have to have their blood drawn fairly frequently. There is also, unfortunately, a problem with the fact that this is a salt, so anything that affects salt balance will throw off the balance of lithium. So if a patient exercises a lot or sweats a lot, that will excrete a lot of sodium, and then the lithium levels will be too high. And so there is a really delicate balance to be found. In terms of the pharmacodynamics, there are, again, no psychotropic effects in healthy patients. That seems to be much like major depressive disorder, that lithium likely affects intracellular processes. So when we talk about treating depression, we believe that the primary effects of antidepressants are affecting intracellular processes. Seems to be the same thing with lithium. Lithium appears to have a neuroprotective effect and possible neurotrophic effects, much like the antidepressants did. Untreated bipolar disorder is associated with decreased cerebral gray matter volume in some very important brain areas. And in fact, treated bipolar disorder appears to, with lithium, appears to help boost neural growth in those areas. So again, probably related to BDNF that we talked about before. I don't want to get too down the rabbit hole with that stuff. But just understand that this seems to be affecting the health of the neurons themselves. So that's a little bit about how the drug works. Let's talk about its side effects and toxicity, because this is the problem. It's very effective, most effective in treating bipolar disorder, but it's not without its problems. So there tends to be some severe disruptions in memory and cognition. This seems to be the side effect most related to noncompliance. That is, people don't like the way they feel because their memory and their cognitive functioning has been so disrupted. There are some serious risks for side effects. Anything that decreases kidney function will affect lithium levels. So there's a very delicate balance in keeping a patient hydrated with enough salt. Really is kind of a delicate balance to maintain. So anything that includes reduced renal clearance, that is, the kidneys functioning less, organic brain disorder, if the patient gets sick with vomiting or diarrhea, any use of diuretics, or low sodium intake or high sodium excretion, again through heavy sweating, all of these are at risk for the toxic side effects of lithium because the amount of lithium relative to other salts will be increased because the other salts will be decreased. The side effects associated with toxicity include tremor. Again, we get cognitive impairment. That's just regular side effects. You can get nausea and weight gain, increased urination, hypothyroidism to the point that the patients can actually end up with a goiter. And then finally, severe toxicity if the balance of lithium levels is off. This is critical because this is a potentially fatal side effect. So that's really important to keep in mind. So this is a difficult drug to maintain people on, but it is incredibly effective. It may oftentimes be used as a transitional drug while another drug is tried out. Some other issues in lithium treatment, really one of the biggest issues is lithium is a teratogen. In fact, almost all of the drugs used to treat bipolar disorder are teratogens, and that is they cause burst effects. And so it's not advised for use during pregnancy. Other drugs should be considered. Unfortunately, there aren't very good alternatives. There are significant side effects of lithium that result in significant noncompliance. And it has been shown that lithium is most effective when used in combination with an anti-epileptic or antipsychotic. So one of the other mood stabilizers in conjunction with lithium is probably the most effective route to go. Next time we're going to turn and talk to those neuromodulator or anticonvulsant mood stabilizers using antipsychotics and some other alternatives for treating bipolar disorder.